Welcome back. We've now seen the anatomy of the respiratory system, and now we can start to talk more about the physiology and the process of breathing itself here. So, breathing is what we would refer to as pulmonary ventilation. And so the lungs themselves need to be ventilated, and this is going to involve both an inspiration and an expiration. And so we're going to get air to move into the lungs, and then we're going to expire the gases after we have taken what we need and given back what we don't want anymore. In order for this to occur, we need to kind of explore a little bit of physics in a sense, in that we need to look at pressures. And so the ability to get air to move in and out of lungs is centered around atmospheric pressure. And so atmospheric pressure is the pressure that is pushing down on us by the atmosphere itself. So if we think about kind of pressure, and what's kind of all around us. Here we have the ground, and then in terms of the atmospheric pressure, it is all of the air and the gases and things that are inside the air and the gases pushing down on us. And so if we were to make, in a sense, a column, and then that column was filled with different substances inside, draw a bunch of different colors in here. And each one of them essentially represents a molecule or molecules of a particular substance. So we've got oxygen, we've got carbon dioxide, we've got nitric oxide, we've got anything and everything. We've got water vapor, other gases and things there. Anything and everything that's in there makes up our atmospheric pressure that we have. And at sea level, we say that this is 760 millimeters of mercury. And so that's how we measure that actual pressure that's there. The higher up we go, so if we go up in elevation, there's less of that column pushing down on us. So our atmospheric pressure is lower. The further down we go, the closer we get to, say, sea level, the more of that column there is above us. And so that's where we have this change there within the pressures. And we're going to have to be able to change the pressure inside our lungs in order either to bring in air into the lungs. And when we do that, we're going to have a negative respiratory pressure. And then in order to get the air to move out of the lungs, we're going to have a positive respiratory pressure. And so this is going to change those pressures. So just like with many other things that we've talked about in terms of things like concentration gradients and so on, we always move from a high pressure towards a low pressure in this sense. And so a positive pressure is going to get us the ability to expire, and a negative pressure is going to get us the ability to bring the air in with inspiration. So it's not just necessarily the air inside the lungs, but the air inside the lungs itself is what we call the intrapulmonary pressure. So this is the pressure inside the alveoli. So this is the air pressure that's inside the actual alveolus itself. But we also have an intrapleural pressure. That intrapleural pressure is the pressure that's in the pleural cavity. And remember, we have the chest wall and the lung itself. So there we have our lung, and we'll do the chest wall in a blue or a darker blue, and that chest wall that's in between there. And then in between there, we have that pleural cavity. And so a little bit of fluid in there, but this also has a pressure as well. And so we have an intrapleural pressure, we have a intrapulmonary pressure, and then we also have atmospheric pressure. And so those three pressures are what we're going to have to, in a sense, monitor in order to determine whether air is going to move in or out of the lungs as we change those pressures around. So intrapulmonary pressure and intrapleural pressure are going to change. And so on a moment-to-moment basis, atmospheric pressure really isn't going to change all that much for those things. And so intrapleural pressure, intrapulmonary pressure, this is what's going to either rise and have a positive pressure or lower and have a negative pressure to move the air in and out of the lungs themselves. With the pressures that we have there, the intrapulmonary pressure, so that's the pressure inside the alveoli, that pressure can become equal to atmospheric pressure. If we have in equalized intrapulmonary pressure and atmospheric pressure, we're going to get no gas movement. And so if we have the same pressure inside the lungs as we do outside of the body, there's going to be no net movement because we have an equalized pressure there. The intrapleural pressure, though, we never want to equalize, and the intrapleural pressure is always going to be less than intrapulmonary pressure. And so it's going to be less than that intrapulmonary pressure, which means it's always going to be less than atmospheric pressure as well. So we have things that are kind of changing the pressures inside the chest and inside the lungs themselves, factors that are going to lead to a difference in the overall movement of gases themselves. And so if you've ever blown up a balloon, you know that a rubber balloon has elasticity to it. And at times, that elasticity, when you go to first blow up the balloon, is almost insurmountable. We can't get above that pressure. The balloon just doesn't want to blow up. In our case, the thing that is keeping our lungs, in a sense, from blowing up is more so the surface tension of the fluid inside our alveoli. And so this is the fluid that is inside there that's always kind of pulling the lungs closed even further. The elasticity of the lungs is going to be altered based on a few different factors that are there. But essentially, just like when we blow up a balloon, that balloon, as we blow it up, it wants to shrink back down to its regular size. And so the elasticity is going to essentially also want to collapse the lung down. And so both of those are going to be pushing the lung into a closed environment. And so trying to make them as small as possible once we have them there. From there, we also have the chest wall itself. And so we have things like the muscles that are there. We have the ribs and so on that is always kind of pulling on those components there. And again, remember we have the actual lung itself, and then we have the chest wall, and then we've got our little bit of fluid in between that is there, creating kind of almost like a suction in between the lung and the chest wall. And that helps to pull the lung outward with the chest wall itself as it expands. So we have to be able to change the pressures. Those pressures change based upon our movement of the diaphragm. And so when we have our inspiration, and so as we're inspiring within the lungs themselves, that means that in order for air to come into the lungs, we have to have a lower pressure inside the lungs than we do outside in the atmospheric pressure. So here we have our 760 millimeters of mercury of atmospheric pressure. If we want air to come into the lungs, we've got to go below that. And so our lung pressure here, our alveolar pressure, is at 758, so that's going to draw the air in towards the lungs. And you'll notice as well that the intrapleural pressure, before we said that intrapleural pressure had to be both lower than the alveolar as well as the atmospheric pressures. So both of those have to be below that of atmospheric pressure in order for air to come into the lungs. When we stop inhalation or even exhalation, that's where we're going to get, so after we inhale, even though the picture doesn't really show the process there, so we have inhalation and then it goes right into exhalation. So as the diaphragm relaxes, that then allows for all of that elasticity to start to relax as well. And now all of a sudden our alveolar pressure goes up. It's now at 762. Our atmospheric pressure stayed the same. So it's now above. So the air wants to leave the system. And once again, the intrapleural pressure is still below that of atmospheric and alveolar. So now the person has exhaled. We've gone through the process of getting the air out of the lungs. And if they hold their breath at that point, that means that our atmospheric pressure is going to be at 760. Our alveolar pressure is at 760. And once again, the intrapleural pressure is still below both of those. And so we've got no net movement because the atmospheric pressure and the alveolar pressure are equal to one another. And so we get no net movement as that occurs. So if I take a breath in, and hold it, there's no air movement because the pressure inside my lungs and the pressure inside in the atmospheric pressure are both equalized. Same thing goes for exhalation. What doesn't happen here is that the lung and the intrapleural pressure become one and the same. That would be something where we would have something called atelectasis. And so atelectasis, or lung collapse, is where that pressure becomes equalized. And so if we equalize the intrapleural pressure with the intrapulmonary pressure, now we're going to have the potential to where the lung collapses down. This can sometimes happen in just a single lobe, but oftentimes it's going to happen to the entire lung itself. And so the pressure across or between the two spaces is our pulmonary pressure minus our pleural pressure. And so we're going to have the difference between those, and we should always have a number that is not equal to one another. Because when that does happen, then we end up having lung collapse. And so on the right side of the picture here, the left side of the body, we have lung collapse. There's no more air inside the lungs. Air in the chest film is going to look like it is still dark, like on the right side here. But because the lung is collapsed, there's no air inside of it. All we see is the lung tissue inside of the chest there. This one here is actually a lobar atelectasis, and so here we have just a single lobe that has collapsed, and the rest of the lung is doing just fine in a sense. And so this can happen sometimes with things like pneumonia, where a person is coughing really, really hard, and it kind of causes. So pulmonary ventilation itself is the process of getting the air to come in and out of the lungs. This is going to be a mechanical process that involves the diaphragm. So the diaphragm is going to change its shape. It's going to go from a dome shape to almost a flattened shape as we breathe in and out. And so here we would have expiration. Here we would have inspiration. That's going to also change the volume of our thoracic cavity as well. And so we're going to have a decreased volume here. We're going to have an increased volume here. And that's also then going to change the pressure. So in terms of our space that is there with an increase in volume, we get a decrease in our pressure. And with an increase in a decrease in the volume, we get an increase in the pressure. And so that's going to move either air in or out of the lungs themselves. And so this is going to allow us to change that pressure in and out, and we're then able to ventilate the lungs. That principle of just simply changing the volume that's there is what we call Boyle's law. And so Boyle's law looks at essentially the amount of pressure in a given space. And so for a given volume that we have. And so it's the pressure and volume relationship between one another. And so we have a pressure in our first scenario. So this would be our equals V1. The pressure here is 1 atmosphere. That equals P1. So P1 and V1. And then we have a volume in our second scenario. So that equals V2. And then we have a pressure in our second scenario. That equals P2. And so the two of them are going to equal one another. So 1 times 1 equals 1/2 times 2. And so we end up with 1 equals 1 for our changes there. So if we simply change the volume of our chest, so this would be our flat diaphragm, this would be our domed diaphragm. We changed the volume, we made it smaller inside the thoracic cavity, and that increases the pressure, and air then goes out, or at least it wants to. In this particular scenario, it can't go anywhere because we have those gauges there. Otherwise, the air would escape out of that tube there. So when it comes to inspiration and expiration, the inspiratory process has to be active. And so in order to get the diaphragm from that dome shape to a flattened shape, we need to have that diaphragm itself actively contract. The majority of the time, just the diaphragm alone is sufficient. So this is what we have when we have our kind of normal restful breathing. But we can also enlist the help of things like our external intercostal muscles. These are what lie in between the ribs themselves. And this is going to help to pull the rib cage up once it's there. We also have muscles of the neck. Things like our sternocleidomastoid is going to help to bring that first rib in the clavicle up as well and pull on them. The pectoralis minor is going to potentially help with that as well as we take a deep, deep, deep breath in. And so, but those don't need to be used all the time. As the lung inflates, the lung itself is stretched. And with that, our volume increases. So the lungs get stretched out because again, we have the lung, and then we have the chest wall. And as that chest wall moves outward, it's going to draw the lung with it. And so it kind of gets pulled with it and it gets stretched out. That is going to increase the volume of the lung. That there then is going to cause the intrapulmonary pressure to drop, and it's going to start to fall. And so that can drop just a millimeter, it can drop a couple of millimeters, all depends upon how forcefully and how much we start to bring that in there as far as the movement of the diaphragm itself goes. So air is going to go from the high pressure of the atmospheric pressure towards the low pressure of the intrapulmonary pressure, and it's going to continue to flow down that pressure gradient. So inspiration involves the diaphragm primarily. We've got our external intercostals. So the external intercostals go with inspiration, and the internal intercostals we'll see goes with expiration. So external intercostals are for our inspiratory process, and then the external intercostals are going to be for expiration. But for the most part, expiration is passive. Again, with restful breathing, just kind of sitting there, not really doing anything, or even just lightly walking or things like that. Expiration can be essentially passive. And so all that we have to do is simply stop contracting the diaphragm, allow the diaphragm to go from being flattened to relaxing into its domed shape. All of the elasticity that we stretched out in the process of inspiration, things like the lungs themselves, the thoracic cage itself is going to start to fall down. All of that recoils and starts to pull down on the lungs, and that's going to cause our volume inside the lungs to start to decrease. With decreased volume, we get an increase in pressure. And so our intrapulmonary pressure is now going to rise. That's going to become above atmospheric pressure, and air then starts to flow out of the lungs themselves. And so that's going to continue to flow out and flow out and flow out until we end up with a zero pressure gradient and we can't get any more air out. So once again, the diaphragm just simply has to relax. It doesn't have to do anything really. The lungs themselves, their elasticity in the lungs will start to cause them to start to deflate once they're inside there. And if we really, really need to cause the lungs to start to exhale, we're going to start to use our internal intercostals. And then at the same time, we're going to use things like our abdominal muscles to try and force the air out. Think of coughing or sneezing, things like that. Utilize our abdominal muscles to help with that process. And with that, we're done with the inspiratory process itself and expiratory process. And we'll pick it up again next time, starting to look further into the gas exchanges.